clot, 500 cc clot. What's the blood loss? How much does the patient lose? With a 500 cc clot? Half a liter? Doctor. What is PCD? PCD, or hemoglobin level, hemoglobin concentration. It's the percentage of the red cell mass to the total volume. What's the average? What's the average? Just average. 40 for a healthy adult. Women, it's roughly three times the hemoglobin. On average, women during their pregnancy would have a hemoglobin of 10.5. So their PCD is given 33%. So this clot represents 33% of the actual blood loss. So this patient must become 1.5 liters per blood. Okay, an underestimation. You see a clot, you multiply by 2. So 500 cc blood is 1.5 liters of fluid, of total blood volume. If there are reasons to suggest that there might be blood loss that is not recognized or recognized, then we need to check the hemoglobin level. So post-cesarean we do it. Post-vaginal delivery only if there is postpartum delivery or postpartum. White cell count, do we need to check them? We don't. Unless there are other indications. She has chorioamnitis or pyelonephritis, whatever. One of the most important things is reducing the risks. Postpartum, حكينا hemorrhage 1, second is thromboembolic accidents. قلنا حكينا المحاضرة الماضية. Pregnant women have 5 times higher risk of thrombosis. Postpartum women have 80 to 80 times the risk of thrombosis. So it's a very significant risk. Very significant risk. And all patients who deliver will undergo risk assessment for thromboembolic accidents. According to the risk, they will either have just stockings, or 5 days anticoagulation, or 10 days anticoagulation, or 6 weeks anticoagulation, if they have high risk. Immunization, which means we give something for the immune system, either stimulated or suppressive. The commonest immunization that happens postpartum should be antibodies. And is it passive or active immunization? What do we call it? It is passive. We're giving the antibody. Active, we give the antigen to stimulate the immune response. Cerebellum in the passive is limited for the half-life of the antibody. It will not give a lasting immune response. While active vaccination will result in permanent or lasting immune response. Now for anti-D, this is passive. But also, if somebody has, if we tested somebody for rubella immunity during the booking investigation, which is risk assessment because of rubella infection can infect mothers and affect the fetuses. If they have no immunity, which is probably because they didn't respond to the childhood vaccination, not an MMR, mom's measles vaccine, rubella early in life. So if they didn't uptake the antigen, we need to re-vaccinate them up. Now we give them which antigen? Which antibody? Antigen or antibody up here? And do we give active or passive? We give them active vaccination. So we give them the antigen. Okay. So what procedures do we do in the postpartum period? As the man, لأنه الغرب wanted to reduce the birth rate بدول العالم الثالث, they came up with IUCD inserted adrenaline. I think I used to encourage it, but this seems to be one of the things that we don't recommend at all. We doubt its success, and we didn't use it at all. But IUCD insertion at delivery was one of the notions that was prevalent at some point, but that's not recommended anymore. There are other methods of contraception. There are other reasons why we shouldn't give contraception at the delivery. Because one of the complications of ISD insertion is vaginal bleeding. So if a woman after ISD insertion and delivery has vaginal bleeding, we don't know if that's due to the ISD itself, or whether she has retained products, or she has polycarcinoma as a cause of her bleeding. So it's not recommended to start the contraception unless we know the patient is healthy. One of the methods that we use is sterilization by tubal ligation, which we can do immediately because it has nothing to do with the pathology of the uterus. So tubal ligation can be done, especially during a cesarean section. So we clip both tubes and we chop a small piece to send to the histology lab to confirm that we did complete amputation of the cervix. The aim is to block the passage through the tubes. And for the male infants, we have circumcision, which is done according to religious beliefs at various stages after the baby is born. Okay, so we need to know that women will have certain needs postpartum. And these are the things that we call morbidities. One of them is pain. Now pain depends on the method the patient has delivered and the complications she had. So all will have what we call after pain. We try to practice autolysis, ischemia pain, very painful, but can be treated with simple analgesics, oral analgesics. We can use paracetamol and we can use non-steroidal anti-inflammatories. Episodic pain, again, is the same. It can be controlled by oral analgesia, but also we can add local anesthetic or local analgesia. Check it out. That's for the episodic pain. However, cesarean section scar pain or cesarean section pain is usually more profound as a pain source and might need opioids. Nowadays, we have options like if we do epidural, we leave the epidural in place for the postpartum pain relief. We can get 24 hours after delivery the epidural running so that patients will not feel the pain. Our issue is mechanical block, which is blocking the nerves, feeding the cesarean section area, and that will work for around 24 hours post delivery. So according to the type of pain, we give the pain relief, either oral, simple, or stronger oral medications, regional or local anesthesia, the spinal, epidural, or tablet, or opioids, the neuroanesthesia. Breast engorgement describes the congestion or describes the production of breast milk and not excreting breast milk from the ducts, which makes the ducts distended with the breast milk after it's produced. If that breast milk is not expressed, it can accumulate infection, eustasis, the anastasis of the urine. That will result in what we call mastitis. What is the treatment of breast congestion? Engorgement. Expression of breast milk. What's the treatment of mastitis? What's the treatment of mastitis? Again, expressing breast milk, not antibiotics. If we leave mastitis, if we don't treat it, as a complication of the infection. Abscess. What's the treatment for abscess? Decision drainage. So antibiotics alone have no role in the management of breast engorgement, mastitis, and abscess condition. Okay, it's supportive, but it's not the main treatment. Now, some patients will not breastfeed, and therefore they will have breast engorgement, and we need to stop that breast milk production. What's the best way? The best way is the surgical method, which is wearing tight bra, painkillers, and fluids, and not expressing the breast milk. And map of that, and do not express it. Because if breast milk stays in the ducts and the glands, it will suppress breast milk production. So that's the reason. But watching for mastitis and breast abscess, that's the best way. If that doesn't work, then we can give medications. Medications to suppress breast milk production. زي ايش؟ that could suppress breast milk production. بس المشكلة إنه it is associated with sudden maternal death. So it's not something that we should give easily to women. This can have complications. مين اللي بنحتاج نعطيهم breast milk suppression أو يعني نكلم suppress breast milk؟ Patients who have either مثل transmitted death أو stillbirth أو neonatal death. شين stillbirth؟ زين كان عايش وولد IRT معناته بيبي كان متوفي جوا. neonatal death معناته بيبي ولد عايش بعدين توفي. Okay? IRT في transmitted death, stillbirth and neonatal death. Infant death is a death within 1 year. Neonatal death في early في late. Early within 5 days, 7 days, late up till 4 weeks. Okay. بعد ما من الجانب اللي بيكون traumatic, the stretching of the renal skin, especially outside the hilar ring, the pain reflex. That pain reflex will suppress voiding. That's that bottle they cannot void. You go to the toilet, they cannot void, cannot pass urine. Usually this is self-limiting, happen within ساعتين. Some people will have it for 24 hours, and some people will have it for days and even weeks. It's very distressing. They will undergo a catheterization. It happens, needs specialist care to make sure that there is no anatomical abnormality in the tract and the air, the fistula. This could be due to anesthesia, dural trauma, instrumental delivery, cesarean section, etc. What we do to treat them is we give them painkillers if they're in pain. We pain them again, تحنفية, that will stimulate voiding desire. Besides, sometimes warm bath, something simple can help them pass here. المنظمة we move to catheterization. Now, because the delivery itself and stretching the perineum have all the muscles interlaced. And if you're stretching, حتى external anal sphincter will be stretched, becomes paper thin. This will result in mucosa even being thinned out, mucosa of the rectum. So when you show the delivery, look at the rectum and the anus, like the anus بيفتح and gets stretched. That can cause tears in the mucosa, resulting in anal fissures. And the congestion itself, that will pushing, and blood vessels will result in hemorrhoids popping out. So hemorrhoids and anal fissures complicate pregnancy and delivery. Some of them even get thrombosed pipes, 20%, 35% who experience postpartum complications of anal fissure and hemorrhoids. Especially if the baby is large and the pushing time is prolonged or if there is an instrument used. Okay? When the double pushing, you see the risk. When there is very clear, you see the risk of we need to use instrument to not deliver. Generally, postpartum complications can range from needing blood ventilation, support, ARDS, renal failure, with caffeine and postpartum hemorrhage, hyperkalemia, gut feeding, and renal failure, shock, could be due to embolism, and complications with anesthesia, if any issues. سؤال؟ أي سؤال؟ أي شيء صعب؟ هلا صاحي؟ هلا نايم؟